In forensic medicine, before you can establish the cause of a death or even the mechanism or, rule on the manner of death, you have to establish the who.
Right, the identity.
Exactly. Identity is really the absolute first truth, because without a confirmed identity, legal processes they grind to a halt.
Completely.
Families can't grieve with any certainty. Justice is suspended. Identity restores personhood. And that is exactly what we're exploring today. So welcome to this deep dive into the complex world of forensic identification.
It's a really profound clinical and legal responsibility. And to set the parameters right from the start, our mission today is to build a solid conceptual framework for you, the listener. We want to explore how forensic practitioners take emotional certainty and transform it into evidential, scientifically defensible certainty.
Yeah, and a very important disclaimer before we get into the clinical weeds here. If you are a medical student prepping for exams, or maybe a junior doctor revising medico-legal principles, or even a senior clinician brushing up on your forensic foundations, this deep dive is specifically designed to support you as you study the material.
But it is not a replacement.
Right. Absolutely not a replacement for reading the primary text. We highly encourage you to read Chapter 14 of Simpson's Forensic Medicine right alongside this audio. Think of us as your audio study companions. We're here to make the textbook concepts a bit more memorable.
We'll be following the structural spine of Simpson's Chapter 14 sequentially. We're going to explore the themes, the physiological mechanisms, and the medical legal frameworks laid out in the text.
So you are warmly welcomed to our virtual multidisciplinary team today. Over the next hour or so, you're going to be thinking alongside forensic pathologists, odontologists, anthropologists, and radiologists.
That's quite the team.
It really is. Let's open with the introduction of the chapter, which focuses on the medico-legal imperative of identification. I mean, why does identity get lost in the first place?
Well, the text divides this into two distinct categories. Yeah. You have deliberate concealment, and you have unintentional loss.
Deliberate loss is fairly self-explanatory, I'd imagine.
Yeah, someone actively destroying identification documents or altering a body specifically to hinder an investigation. But the unintentional loss of identity, that seems to be what triggers the most massive, coordinated medico-legal responses.
Because we're talking about scale.
Exactly. Unintentional loss happens across a wide spectrum of catastrophic circumstances. We're talking natural disasters, tsunamis, wildfires, earthquakes, or mass fatality incidents, terrorist attacks, industrial explosions, major aviation disasters.
Right.
In all of these scenarios, legal authorities and national authorities, not to mention the families of the victims, they require identity to be definitively established before any remains can be repatriated, or death certificates can even be issued.
And it's not just an administrative preference, it is a strict legal requirement. The text notes that in England and Wales, for example, establishing identity is quite literally the very first question that must be answered at a coroner's inquest.
The very first.
You cannot proceed with a death investigation legally until you can say, beyond scientific doubt, who is lying on the autopsy table. But there's a concept here that I think often surprises people outside the clinical field.
The visual identification issue.
Yes. Relying on a family member to just look at the deceased and provide a visual ID is incredibly problematic. Why is the clinical threshold moving so far away from visual identification?
The fallibility of visual identification is a cornerstone concept in forensic medicine. Often, visual ID by an appropriate person, like a close relative, is not just discouraged, it is physically impossible.
Because of the trauma.
Right. We have to consider the biological and traumatic mechanisms that distort facial features, severe facial trauma from a blunt force impact, or just the natural biological processes of putrefaction and decomposition.
Which happen remarkably fast depending on the environment.
Very fast. Add in deliberate mutilation or the highly destructive effects of thermal injury, fire. All of this can render a face completely unrecognizable. The anatomical landmarks we rely on for everyday facial recognition are surprisingly fragile.
So if the soft tissue is compromised, visual ID is out. But the text also points out that even when the face is somewhat intact, human psychology plays a massive and sometimes really disruptive role in the ID process.
Yes, emotional recognition is highly vulnerable.
Yeah.
You're dealing with the shock of trauma and the incredibly powerful psychological defense mechanism of denial.
Right, the brain just rejects it.
Exactly. Consider a grieving parent or a spouse looking at their deceased loved one in a stark mortuary setting. Because the context is so horrific, so out of the ordinary, their brain might simply refuse to process the reality.
So they deny it's them.
They do. leading them to deny the identity of a perfectly recognizable relative. And conversely, people desperately searching for a missing loved one have been known to positively identify remains that bear only a passing morphological resemblance to their relative.
Just purely out of a psychological need for closure.
Yes, they need the agonizing ambiguity to end.
That makes perfect sense. The brain either rejects the trauma or forces a false positive. Therefore, scientific identification cannot rely on emotional recognition. It has to rely on objective, measurable metrics.
And as we'll see, this multidisciplinary team doesn't just work with the deceased.
Oh, right, the age estimation.
Yeah, a fascinating aspect of Chapter 14 is that these exact same principles and experts are frequently called upon to estimate the age of the living, specifically in high-stakes legal scenarios, like determining criminal responsibility or assessing asylum applications.
We'll definitely get into that later because the ethics there are wild. But first, let's build our core framework. Chapter 14 divides identification criteria into two main categories: primary and secondary.
This is the fundamental classification system you need to anchor in your clinical thinking right now. Primary identification criteria are the gold standards.
Meaning they stand alone in court.
Exactly. They're scientifically robust enough to stand entirely alone in a court of law to establish identity. According to the textbook, there are three primary criteria: fingerprints, DNA profiling, and dental records.
Okay, let's unpack this. Those are the gold standards. But the text also includes a crucial, fairly modern caveat about these primary methods. The absolute specificity of some fingerprint and dental assessments has actually been brought into scientific and legal question in recent years. How has the field adapted to that scrutiny?
It has adapted through the implementation of highly rigorous standardized methodologies and blind verification processes.
Because it used to be a bit more subjective, right?
Very much so. Historically, a fingerprint examiner might have declared a match based on a somewhat subjective assessment of a certain number of minutia points, the ridge endings and bifurcations on a print. Similarly, forensic odontologists might have made highly confident assertions about bite marks or dental anomalies.
And defense attorneys started tearing that apart.
Yes. Landmark legal challenges and scientific reviews highlighted the potential for cognitive bias and interpretative error. Today, they absolutely remain primary criteria, but their application requires strict adherence to standardized analytical protocols.
You can't just eyeball it and declare a match anymore.
No, the interpretive standards are incredibly stringent now.
So those are the primary criteria, strictly methodological. Then we have the secondary criteria, which act as the supporting cast. What are the key secondary markers that clinicians and investigators are documenting?
Secondary criteria encompass a really wide array of physical and circumstantial evidence. This includes unique medical characteristics.
Like what?
Say, a rare congenital deformity or a specific surgical procedure. It includes distinctive marks, tattoos, and surgical scars. Radiological evidence is huge here, comparing a post-mortem chest X-ray to an ante-mortem X-ray to match the unique trabecular pattern of the clavicle. That's a powerful secondary tool.
And I assume personal effects.
Yes, personal effects, jewelry, distinctive clothing. The text also mentions some additional highly specialized tech like gait analysis or facial profiling from CCTV cameras.
So if secondary criteria are so varied and abundant, how do they actually interact with the primary methods during a real investigation? Can a unique combination of secondary features ever legally replace a primary identifier?
Generally speaking, no. Secondary features support and corroborate primary methods, but they rarely replace them entirely on their own, unless the circumstantial matrix is overwhelmingly unique.
So they point you in the right direction.
Exactly. Finding a wallet with a driver's license in the pocket of a deceased individual is your classic secondary identifier. It suggests a presumptive identity. It gives investigators a name to start researching, a family to contact.
But legally, you still don't know it's them.
Right. Does not prove the body belongs to the person on the license. People carry other people's IDs all the time. To cross the threshold into evidential certainty, you must transition to a primary method.
Like taking a DNA sample from the body and matching it to a known medical sample from the person on the license.
Precisely. Secondary criteria, build the hypothesis. Primary criteria, prove it.
That perfectly sets up Section 3 of the chapter DNA profiling. We need to look at the biology of the genetic barcode. Now, the text moves past the basic high school biology of the double helix, the adenine, thymine, cytosine, guanine, and dives straight into the forensic application. And there's a surprising fact highlighted here about how much of the DNA molecule is actually used for active genetic coding versus what forensic scientists use for identification.
It's a critical biological distinction. Only about 10% of the human DNA molecule is used for active genetic coding.
10%, that's it.
That's it. These are the genes that determine your phenotype, your eye color, your height, the specific proteins and enzymes your body synthesizes. The remaining 90% of the DNA molecule does not code for proteins.
Which people used to call junk DNA.
Right. Historically, it was termed junk DNA, though we now know it has complex regulatory functions. But we refer to these areas as the silent zones. And it is entirely within these silent, non-coding zones that modern forensic DNA profiling operates.
If these zones don't code for our physical traits, what exactly is inside them that allows forensic scientists to differentiate one human from another?
Within these silent zones, there are repeating sequences of identical base pairs. We're talking anywhere from 200 to 13,000 repeats of specific identical sequences.
And Sir Alec Jeffreys figured this out in the 80s.
He did. He discovered that the length and pattern of these repeating sequences are highly variable across the human population, yet they are constant for any given individual.
Because we inherit them.
Crucially, yes. They are inherited in a Mendelian fashion from our parents. Half from the mother, half from the father. Because of the vast statistical variation in the number of these repeats across different locations on the genome, a comprehensive DNA profile can be considered statistically specific to one individual.
With one exception.
Monozygotic twins, identical twins.
Right. Now, the technological evolution described in the chapter is staggering. It walks us through the transition from early DNA fingerprinting to modern genetic profiling. If early DNA testing required high molecular weight DNA, meaning large, high-quality samples of blood or semen, how did investigators handle degraded trace evidence at scenes back in the day?
Often, they simply couldn't.
They were just out of luck.
Pretty much. If biological evidence was highly degraded by environmental exposure, or if there were only a few cells present, the older technique restriction, fragment-length polymorphism, or RFLP, would fail to yield a profile.
And it had tissue matching issues too, right?
Yes, RFLP required matching tissue type to tissue type. You generally needed blood to match with blood. If a suspect left a tiny smear of saliva at a scene, and you only had a blood sample from the suspect, the comparison was incredibly difficult, if not impossible.
Which obviously severely limited the forensic application. But the game completely changed with the advent of the modern standard outlined in the text.
The revolutionary leap was the widespread forensic adoption of the polymerase chain reaction, PCR.
The molecular photocopier.
That's the perfect metaphor. PCR effectively acts as a molecular photocopier. It allows forensic scientists to target much smaller repeating sequences known as short tandem repeats, or STRs.
So even if you have almost nothing to work with.
Exactly. If you only have a minute trace of DNA, PCR uses thermal cycling to replicate that specific STR region exponentially until there is a sufficient quantity of DNA to analyze and visualize. This completely replaced the old RFLP methods. It became the undisputed gold standard in forensic genetics.
The clinical precision of modern PCR-based STR analysis is mind-blowing to me. The text notes that modern STR multiplex systems can simultaneously amplify up to 30 STR loci, which are the specific locations on the chromosomes, from an incredibly small biological sample. We are talking about generating a full profile from as few as 15 cells.
15 cells. The medico-legal implication of that sensitivity changes the entire landscape of criminal investigation. Because we're looking at DNA at the cellular level, the old requirement of matching blood to blood is entirely obsolete.
Because every cell has the whole code.
All nucleated cells in an individual's body contain the identical genetic code. This means a simple, non-invasive buccal swab, gently scraping the inside of a suspect's cheek to collect shed epithelial cells, is completely sufficient to generate a comprehensive genetic profile.
And then you can match that cheek swab to anything.
That buccal profile can be definitively matched against a microscopic trace of semen, a single drop of blood, or even epithelial cells left on the rim of a drinking glass at a crime scene.
But this incredible sensitivity brings us to a major clinical and investigative vulnerability. On one hand, you have the immense benefit of solving cold cases. Because we can now analyze smaller and smaller amounts of degraded DNA, historical evidence from decades ago can be retested. Incorrectly convicted individuals are being exonerated, perpetrators identified. But what is the fundamental risk when your analytical tool can amplify 15 invisible cells?
The profound risk is cross-contamination.
It has to be a nightmare to manage.
It is a critical operational point for any forensic practitioner, pathologist, or scene investigator to grasp. because PCR is designed to amplify minute traces of DNA indiscriminately. Crime scenes, mortuaries, and mass disaster scenes represent massive hazards for DNA transference.
Just breathing on something could ruin it.
Literally. If a scene investigator sneezes or sheds skin cells from an exposed wrist or inadvertently touches a piece of evidence with a contaminated glove, they will deposit their own biological material.
And the machine doesn't know the difference.
The PCR process will dutifully amplify the investigator's DNA alongside or potentially completely obscuring the actual evidence.
How is that risk managed from a strict medico-legal standpoint to ensure the evidence actually holds up in court?
It necessitates absolute, uncompromising adherence to standard operating procedures, SOPs. Scene investigators and forensic pathologists must wear highly specific protective clothing, full-body suits, masks, hairnets, double layers of gloves that are changed frequently.
You're essentially creating a physical barrier.
A barrier between the practitioner's biology and the evidence. Furthermore, to manage the reality that trace contamination might still occasionally occur, many jurisdictions have implemented a strict legal and operational requirement for all personnel involved in the identification, collection, and analysis of samples to provide exclusion DNA samples.
Right, so the authorities maintain a secure database of the DNA profiles of all the police officers, the crime scene techs, the forensic scientists.
Everyone in the chain.
If a random profile pops up during the analysis of a crime scene exhibit, they can cross-reference it with the exclusion database. If it matches a lab technician, they can immediately identify the contamination event, isolate it, and prevent a massive misdirection of the investigation.
Exactly. It safeguards the integrity of the evidence by making contamination instantly identifiable.
Now, before we conclude our discussion on DNA, the text touches upon a cutting-edge advancement that bridges genetic profiling with age estimation. While a standard DNA profile is static, your genetic barcode doesn't change from birth to death. Researchers have recognized that the epigenetic signature of DNA actually changes over an individual's lifespan.
Yes. The text specifically mentions DNA methylation.
For a clinical audience, what is the actual mechanism here? How does methylation act as a biological clock?
Epigenetics refers to changes in gene expression that do not involve alterations to the underlying DNA sequence. DNA methylation is a specific epigenetic mechanism where methyl groups, these are small chemical tags consisting of 1 carbon and 3 hydrogen atoms, are added to the DNA molecule, typically at sites called CPG islands.
And these accumulate as we age.
As a person ages, environmental exposures, cellular replication, and natural metabolic processes cause the pattern and density of these methyl tags to change in a highly predictable manner across specific regions of the genome.
So it's measurable.
Highly measurable. By using specialized assays to measure the density of DNA methylation at these targeted sites, forensic scientists can calculate a relatively accurate estimate of the individual's biological age.
That is a phenomenal biological mechanism. The genetics give you the specific identity, but the epigenetics might tell you exactly how old that person is, which is incredibly useful if you only have a drop of blood from an unknown suspect and no matches in the database.
It gives investigators a tremendous lead.
Let's shift our focus to Section 4. The examination of dental structures, universally known as forensic odontology. Why are teeth such a massive focal point in forensic identification?
It comes down to basic anatomy, physiology, and extreme structural resilience. Dental enamel is the hardest, most highly mineralized tissue in the human body.
Tougher than bone?
Much tougher. In scenarios like mass disasters, terrorist bombings, aviation crashes, or severe fires where the human body is exposed to extreme destructive forces, forensic odontology is absolutely paramount. Teeth can survive the complete putrefaction and decomposition of all surrounding soft tissues.
They survived being underwater for months, too.
Prolonged submersion in water, yes. Furthermore, the dental pulp chamber deep inside the tooth acts as a physically protected reservoir. Even when the outer body is severely degraded, high-quality DNA can often be extracted from the vascular tissue within the pulp cavity.
The text constantly hammers home the principle of comparison here. A forensic odontologist can meticulously examine a deceased person and chart every single filling, every root canal, every extracted tooth, every crown. But that highly detailed post-mortem chart is forensically useless in a vacuum, isn't it?
It completely is. The fundamental essence of identification by dentition relies entirely on the availability of ante-mortem records.
You need something to match it to.
The forensic odontologist requires pre-existing clinical charts, dental molds, and radiographic images, specifically bite wing or panoramic x-rays obtained from the individual's general dental practitioner. The odontologist then systematically compares the ante-mortem records with the post-mortem findings.
And if they line up perfectly.
If the unique constellation of dental interventions matches, a positive identification is confirmed. However, the text does note a frequent practical hurdle. The clinical records maintained by general dental practitioners are sometimes outdated, or inaccurate, or incomplete.
Which forces the odontologist to play detective a bit.
It severely complicates the comparative process and requires extensive deductive reasoning based on the materials used in the fillings, the style of the dental work, things like that.
The chapter goes into incredible physiological detail about what actually happens to the mouth and teeth in a severe fire. I love this part because it's a perfect example of why you need to understand the underlying pathology to interpret the forensic findings at a scene. Walk us through the physical mechanism of thermal injury on the dentition.
When a body is exposed to severe fire, the anatomical structures of the head and neck interact in highly specific ways. Interestingly, the teeth are actually quite well protected initially.
By the tissues of the mouth.
Yes. As the environmental temperature rises, massive physiological changes occur in the soft tissues. First, the intense heat causes the tongue to swell dramatically. This massive swelling physically covers and thermally insulates the lingual surfaces, the inside surfaces of all the teeth.
Okay, so the inside is safe. What about the outside?
Secondly, the ramus of the mandible, the vertical portion of the jawbone, along with the thick, muscular, and adipose tissues of the cheeks, offer significant thermal protection to the buccal or outer surfaces of the posterior teeth, specifically the premolars and molars.
So even in a highly destructive fire, the back teeth might remain relatively intact, but the anterior teeth, the front teeth, face a very different anatomical reality.
They do. The anterior teeth, the maxillary and mandibular incisors, and the canines are highly vulnerable because they are only protected by the lips.
Which are pretty thin.
Relatively thin, purely soft tissue structures. As the ambient temperature rises, the soft tissue of the lips loses moisture rapidly, desiccates, and shrinks away,
Leaving the teeth totally exposed.
This tissue retraction effectively leaves the anterior teeth totally exposed to direct heat and flame. In a fierce or prolonged fire, these unprotected anterior teeth become what we term calcined.
Calcined, meaning the intense heat fundamentally alters their chemical structure.
Yes, the extreme heat combusts and destroys all the organic matrix within the tooth, leaving behind only the fragile, inorganic mineral structure, primarily hydroxyapatite.
What did they look like at that point?
These calcined teeth appear chalky, white, or gray. Crucially, they will maintain their exact anatomical shape as long as they are perfectly undisturbed.
But they're fragile.
Incredibly brittle. The absolute slightest mechanical force, even just the vibration of moving the body, a gust of wind, or a light touch from a gloved hand, will cause them to instantly crumble and disintegrate into a fine powder.
And losing those front teeth is a massive blow to the forensic investigation. While the posterior molars might house the amalgam fillings or crowns used for clinical charting, the anterior teeth dictate the cosmetic appearance of the smile.
Which is vital for photographic superimposition.
Exactly. If investigators cannot locate dental records, they might need to use photographic superimposition, comparing the skull to a smiling photograph of the victim. You cannot do that if the front teeth have turned to dust. How does a forensic odontologist prevent this disintegration at a fire scene?
This brings us to a highly specialized, absolutely vital scene preservation technique detailed in the text. When a forensic odontologist attends a fire scene, their immediate clinical priority, before the body is ever moved to a body bag or transported to the mortuary, is stabilizing those calcined anterior teeth.
How do they do it?
They achieve this using a specific dental material called transparent cold cure acrylic, which is a type of polymethyl methacrylate.
How is that actually applied to something so fragile? You obviously can't brush it on if a breath of wind will break them.
It requires extreme delicacy. The acrylic consists of a liquid monomer and a powder polymer. The odontologist mixes the powder and liquid at the scene, purposefully creating a very thin, runny consistency.
And then?
Then, using a dropper or a fine instrument, they gently drip this liquid acrylic directly over the fragile calcined teeth. The liquid monomer seeps deeply into the porous, delicate ash structure through capillary action. Within a few minutes, the acrylic polymerizes and sets solid, effectively plasticizing the calcined teeth.
That is a brilliant clinical intervention at the scene. It preserves the exact morphology of the teeth so they can survive the physical trauma of being transported to the mortuary for x-rays and examination.
It's essential.
The text also mentions securing a clear plastic bag over the head of the deceased just in case any stabilized fragments do dislodge during transit, ensuring they are retained within the body bag for later reconstruction.
It is the ultimate example of combining clinical chemistry with forensic chain of custody principles.
Let's transition into Section 5, where we examine other primary and secondary methods, specifically fingerprints and morphological characteristics. We already established that fingerprints are a primary identifier. But practically speaking, how do fingerprint experts recover friction ridge detail from a body that is actively decomposing or has been submerged in water for an extended period?
It requires highly specialized, somewhat delicate tissue recovery techniques. In cases of prolonged submersion in water, a process known as maceration occurs.
Pruning of the skin, basically.
On an extreme level, yes. The skin absorbs water, becoming pale, wrinkled, and eventually, the superficial layers of the skin begin to loosen and separate from the underlying dermis. This is called skin slippage or desquamation.
And what do the experts do with that?
Fingerprint experts can often carefully remove this loosened skin, sometimes slipping it off entirely like a glove. The technique is literally referred to as gloving. They can then place this skin over their own gloved finger to roll a pristine print.
Wow. What if the outer layer of skin, the stratum corneum, has completely detached and washed away? Are the prints gone?
Even then, all is not lost. The friction ridge patterns that make up a fingerprint are deeply anchored. If the stratum corneum is gone, experts can frequently retrieve the exact same ridge patterns from the underlying layer, the epidermis.
That's incredible.
In cases where the tissue is severely wrinkled or shriveled, they might use a hypodermic needle to inject a tissue builder or saline subcutaneously to plump the finger pad back to its normal anatomical volume.
Just to smooth it out for the ink.
Exactly, allowing for a flat, readable print to be rolled. The text notes that despite recent scientific scrutiny regarding interpretive thresholds, fingerprints remain incredibly useful. For instance, in aviation disasters, victims often sustain massive internal blunt force trauma, but if they are thrown clear of the post-crash fire, their hands may remain relatively intact, making rapid fingerprint ID highly effective.
Moving beyond primary identifiers, the pathologist must compile a comprehensive biological profile based on morphological characteristics. This is the ultimate secondary identification checklist. You obviously cannot legally identify someone solely because they are 6 feet tall with brown hair, but you absolutely must record these parameters with clinical precision to match against known ante-mortem data. What specific data points is the forensic pathologist documenting during the external exam?
The documentation must be exhaustive. The pathologist meticulously records the length of the body representing height, the weight, and calculates the body mass index to describe general physique. They document hair color, hair length, and crucially, any evidence of cosmetic bleaching or dyeing, noting the color of the roots versus the tips. They assess body hair distribution, specifically noting areas that are commonly shaved, which can indicate personal grooming habits or cultural practices.
And they are looking closely at the skin for specific physiological or surgical markers.
Precisely. They're looking for striae stretch marks, which can indicate previous childbirth or rapid weight fluctuations. They document evidence of cultural or religious practices, such as female genital mutilation or specific patterns of scarification.
Surgical scars have to be a big one.
A very big one. They meticulously map any surgical scars, noting their anatomical location, length, and the type of surgical closure, such as suture marks or staple tracks. They also document old healed injuries or congenital deformities, like a club foot or a cleft lip repair.
All of this must be documented photographically as well. High-quality, properly scaled frontal and profile photographs of the face and body are essential. But let's delve into tattoos and body piercings, because this is an area where lay people often make incorrect forensic assumptions.
They definitely do.
Right. So if a deceased individual has a tattoo of a soaring eagle on the right bicep, and a missing person is known to have a tattoo of a soaring eagle on their right bicep, that constitutes a positive ID, correct?
In a strict legal and scientific sense, no.
Really? Why not?
The simple presence of a conceptually similar tattoo does not confirm identification, because thousands of people might have purchased a similar soaring eagle design from a standard tattoo parlor flash sheet.
Oh, that makes sense.
To elevate a tattoo to a strong secondary identifier, it must be meticulously matched to ante-mortem images. You need a photograph of the missing person showing that specific tattoo. The forensic pathologist will then compare the exact design, the anatomical placement down to the millimeter, the specific line work, the shading techniques, and the coloring.
So it's about the unique minutia of the tattoo, not just the general description.
Exactly. Furthermore, unique or highly personalized tattoos, such as specific names, intricate custom artwork, or dates of birth carry significantly more evidential weight than generic designs.
What if a tattoo was removed?
The text highlights the importance of checking for previous tattoo removal. Examining the skin under ultraviolet light or utilizing infrared photography can sometimes reveal the faint pigment remnants of a laser-removed tattoo, providing a highly specific secondary characteristic.
This discussion of tattoos leads us directly into one of the most remarkable historical anecdotes in the entire textbook, the 1935 Sydney shark case, detailed in box 14.1. This case perfectly illustrates how a single secondary characteristic can completely alter the trajectory of an investigation. Let's walk through this incredible forensic narrative.
It is a truly classic case in forensic history that highlights the intersection of strange circumstances and clinical observation. In April 1935, a large tiger shark was captured off the coast of Australia and placed in a public display pool at the Coogee Aquarium in Sydney.
And things took a very dark turn.
A few days into its captivity, the shark began thrashing violently and suddenly vomited up a human arm. The arm was severed at the shoulder, and somewhat bizarrely, it had a length of rope tightly tied around the wrist.
Which is a horrifying spectacle for the aquarium patrons, but an incredibly lucky break for forensic investigators. Despite having been in the highly acidic digestive tract of a tiger shark for up to a week, the arm was remarkably well preserved.
Indeed, the preservation was key. Crucially, the forearm bore a very specific, clearly visible tattoo, a depiction of two boxers engaged in a fighting pose.
A very distinct secondary identifier.
Very distinct. The police immediately recognized the investigative value of this unique marker and circulated a detailed description and photograph of the tattoo in the local press. This public appeal yielded a result.
Someone recognized it.
The tattoo enabled the police to provisionally identify the severed arm as belonging to a specific man who had been reported missing by his family about 9 days prior.
So the unique secondary characteristic, the boxing tattoo, provided the crucial presumptive identification and gave the police a name. But the examination of the arm itself by forensic pathologists is where the legal reality of the case radically shifted.
That is where the pathology took over. When the forensic pathologists meticulously examined the severed edges of the arm at the shoulder joint, they expected to find the characteristic ragged, tearing, crush injuries associated with a shark bite.
Tiger sharks have serious teeth.
Highly serrated teeth designed to saw through flesh and bone. However, the tissue margins and the bone cuts were remarkably clean. The examination definitively revealed that the arm had been deliberately and cleanly cut from the body with a sharp-bladed instrument, not bitten off by an animal.
Which instantly upgrades the legal framework of the case. It is no longer a tragic maritime accident or a simple missing person inquiry. The sharp force trauma transforms it into a full-blown murder investigation.
Precisely. The victim had been murdered, dismembered, and his remains were likely dumped in the ocean, where the shark subsequently scavenged the arm. While a man was eventually arrested and tried for the murder, though he was ultimately acquitted due to complex legal arguments regarding the corpus delicti, the case remains a perfect pedagogical demonstration.
The unique secondary characteristic guided the identification, while the rigorous pathological examination determined the criminal nature of the act.
Exactly.
What a phenomenal intersection of biology and investigation. Let's shift gears to Section 6. We've discussed intact bodies, bodies altered by fire, and bodies subjected to water. But what happens when the soft tissue is entirely gone and you are left only with bones? Box 14.2 outlines the clinical process for the identity of decomposed or skeletalized remains. I like to frame this as the anthropological diagnostic pathway. It is a strict, sequential process of elimination. Walk us through the specific questions a forensic anthropologist asks when potential remains are discovered.
It is a highly structured, scientifically rigorous decision tree. The very first question, which might seem elementary to a layperson but is vital in practice, is, are they actually bones?
Because the public, and even inexperienced police officers, frequently mistake environmental debris for skeletal remains.
They do all the time. Water-worn stones, oddly shaped pieces of thick plastic, or even fragments of heavily weathered wood can mimic the anatomical shape, color, and porous texture of bone to the untrained eye.
So how do you tell the difference at a glance?
Usually, a medically trained person can differentiate them immediately based on the presence of cortical and cancellous bone structures, or by utilizing radiography if the object is heavily calcified. Once the material is confirmed as actual osseous tissue, the diagnostic pathway moves to the second question. Are they human?
And this is where it gets surprisingly difficult. I think most people assume human bones look completely distinct from animal bones.
For major long bones or an intact skull, the differentiation is straightforward for a pathologist. However, identifying highly fragmented remains or specific small bones requires immense comparative osteological expertise.
Which bones specifically cause trouble?
While a forensic pathologist can identify almost all of the human skeleton, certain bones, specifically the phalanges of the fingers and toes and the carpal and tarsal bones of the wrists and ankles, can be incredibly difficult to positively identify as human in isolation.
Why is that?
Because the extremity bones of certain animals, notably bears or large primates, bear a striking morphological and biomechanical resemblance to the human hand and foot. Differentiating a bear paw from a human hand without the claws attached requires an expert anthropologist.
Okay, so we've established the remains are bone and they are human. Question 3 on the pathway. Is there commingling? Meaning, do we have remains from more than one individual mixed together?
This is a vital medico-legal question, especially in clandestine graves or disaster sites. If you open a shallow grave and find 2 intact skulls or 2 left adult femurs, the duplication clearly indicates commingling.
That's the easy version.
Right. But if there is no obvious duplication of major bones, establishing commingling requires meticulous skill. The forensic anthropologist must examine each individual bone fragment carefully, assessing whether the physical sizes, the joint articulations, and the taphonomic appearances, meaning the specific patterns of weathering, soil staining, and degradation, actually match and belong to a single, biologically cohesive individual.
Moving to question 4. What is the biological sex of the individual?
Here, the anthropologist relies heavily on the skull and the pelvis, as these structures display the most reliable sexually dimorphic morphological differences. In the pelvis, they examine the shape of the pelvic inlet, the width of the greater sciatic notch, and the subpubic angle.
Which are generally wider in females for childbirth.
Yes, to facilitate childbirth. In the skull, they look at the robustness of the mastoid processes, the prominence of the supraorbital ridges, and the general muscle attachment sites, which tend to be more pronounced in males. The femur and the sternum can also offer metric assistance.
It's never just one bone, though.
Never. The key clinical takeaway is that an anthropologist will never rely on just one anatomical structure. They score multiple traits across the skeleton to build a statistically robust biological profile.
Which leads directly to question 5. What was the age at death? We will cover age estimation more broadly in a moment, but for skeletal remains, it requires assessing epithelial fusion in younger individuals and degenerative changes, like assessing the pubic symphysis or cranial suture closure in older adults. This contains a massive physiological trap that frequently catches out junior investigators. Why is it scientifically inaccurate to just measure a recently deceased intact body from head to heel to determine their living height?
This is a fascinating intersection of biomechanics and post-mortem physiology. The direct head-to-heel measurement of a corpse on an autopsy table does not equal their standing height in life.
Why not?
There are 2 primary mechanisms at play. First, upon death, there is a profound total relaxation of the skeletal muscles, causing the body to flatten and spread slightly. Second, and more significantly, we must consider the intervertebral discs, the cartilaginous pads sitting between the bones of the spine.
The shock absorbers.
Exactly. During life, the central portion of the disc, the nucleus pulposus, is under constant gravitational compression when we stand, squeezing fluid out. When a person lies flat or dies, that gravitational pressure is removed.
So they puff back up.
Yes. The nucleus pulposus regains its osmotic pressure, absorbing fluid and expanding slightly. This combination of muscle relaxation and the expansion of 23 intervertebral discs means a body actually lengthens post-mortem, sometimes by several centimeters.
So if measuring an intact corpse is inaccurate, how do anthropologists estimate height from a scattered skeleton?
They rely on the measurement of the major long bones. Anthropologists use specialized osteometric boards to take highly precise measurements of intact long bones, like the humerus in the arm, the ulna in the forearm, or the femur and tibia in the leg.
And then they do the math.
They input these specific measurements into established statistical regression tables, which are calibrated for specific sexes and ancestries, to calculate a highly accurate estimated living stature range.
Question 7 on the diagnostic pathway asks, what is the ancestry of the deceased?
This specific assessment sits firmly within the highly specialized realm of forensic anthropologists. that primarily utilize craniometrics, taking very precise, standardized measurements between specific landmarks on the skull to assess ancestral morphological traits. They evaluate the shape of the nasal aperture, the orbital cavities, and the facial profile.
It's a complex area.
It is. While ancestry estimation can be a complex and sometimes controversial area within modern anthropology due to human admixture, it remains an important component of narrowing down the biological profile for law enforcement.
And finally, question 8 brings it all together. Can a personal identity be discovered? You have successfully determined the sex, the estimated age, the stature, and the ancestry. You have a biological profile, but how do you extract a specific name from dry bones?
You look for the absolute gold standard of secondary skeletal identification, surgical implants.
The holy grail of bones.
It really is. If the individual underwent orthopedic surgery during their life and had a medical device implanted, such as a cardiac pacemaker, an implantable cardioverter defibrillator, or an arthroplasty implant like a titanium hip or knee replacement, those devices are forensically invaluable.
Because they don't rot.
They are highly resistant to degradation. More importantly, these devices carry unique reference codes, batch numbers, and specific serial numbers etched into the metal. The anthropologist or forensic radiologist can image the implant, retrieve that serial number, and track it directly through the manufacturer's database.
Right to the patient.
Back to the specific hospital, the specific surgeon, and the specific named patient who received it on a specific date. It is an incredibly powerful, legally definitive identifier.
So we have explored the identification of a single body, whether intact or skeletalized. But what does this entire medico-legal process look like when the scale goes from a single victim to a massive mass casualty event? Section 7 covers mass disasters, or what is officially and internationally termed disaster victim identification, or DVI. The logistics of this must be staggering.
When dealing with events of massive scale, such as terrorist bombings, commercial aviation crashes, extensive train derailments, or natural disasters like tsunamis, the sheer volume of remains and the chaotic nature of the scene necessitate a highly rigid, internationally standardized protocol.
Is there a global standard?
Usually these operations are guided by the Interpol DVI guidelines. The absolute bedrock of any DVI operation is the systematic, methodical collection of evidence and the maintenance of an unbroken, documented chain of custody from the disaster site to the mortuary.
Because if you mix up biological samples or mislabel a body bag in a mass casualty event, the compounding trauma inflicted on the families is unimaginable. And the legal integrity of the entire operation just collapses. DVI is fundamentally about comparison. You need post-mortem data, and you desperately need ante-mortem comparators.
Exactly. The DVI process is essentially a massive, highly coordinated data matching exercise divided into phases. Phase 1 is the scene processing. Phase 2 is the post-mortem examination, where teams of pathologists and odontologists document every physical detail, fingerprint, and dental filling of the recovered remains.
Then they record this on specific forms.
Yes, recording this data on standardized pink Interpol forms. Simultaneously, Phase 3 is occurring, the ante-mortem data collection. Specially trained family liaison officers are deployed to interview the families of suspected victims. They're sourcing ante-mortem data, recording it on yellow Interpol forms.
What specifically are the family liaison officers looking for to build that ante-mortem profile?
They're tasked with gathering the primary and secondary comparators. They are contacting general dental practitioners worldwide to secure original dental charts and radiographic molds. They're going into the victims' homes, with consent, to recover personal items that might yield a known DNA profile.
Like what kind of items?
Items like toothbrushes, unwashed hairbrushes, or used razors. They're also collecting family reference DNA samples via buccal swabs from direct blood relatives, parents, or children to facilitate kinship DNA matching.
And how is all this massive influx of pink and yellow form data actually managed and legally reconciled? The UK has a very specific legal framework for how this is overseen, correct?
Yes. In the UK, the operational police response is coordinated by the National Disaster Victim Identification Unit. However, the legal authority rests elsewhere. Legally, the local coroner, or the procurator fiscal in Scotland, takes lawful possession and absolute control of all deceased persons or human remains recovered from the disaster site.
So the coroner is in charge.
Yes. The crucial phase of DVI is Phase 4, reconciliation. The coroner chairs what is known as the Identification Commission.
So the coroner acts as the ultimate judicial arbiter of identity.
Precisely. It is before this formal identification commission that the multidisciplinary DVI team, the senior pathologists, the fingerprint experts, the forensic odontologists, and the DNA scientists present their comparative scientific evidence.
They lay it all out.
They present the DNA matches, the dental comparisons, and the fingerprint data. The commission rigorously reviews the scientific validity of the match. Only when the coroner is entirely satisfied that the evidence meets the required standard of proof is the identity formally and legally confirmed, allowing a death certificate to be issued and the remains to be repatriated to the grieving family.
Which finally brings us to our last major section, Section 8. Age estimation in the living. We touched on this briefly earlier. Estimating the age of a living person isn't just an academic medical exercise. It has massive, life-altering, real-world consequences.
The clinical and legal stakes are exceptionally high, and it is an area fraught with ethical complexity. Age estimation in the living fundamentally dictates human rights and legal pathways.
Tell us about the criminal justice side first.
In the criminal justice system, establishing age determines whether an individual is processed through the adult courts, where they face full penal sanctions, or the juvenile justice system, where the focus is on rehabilitation, anonymity, and significantly less severe penalties.
And then there's immigration.
Furthermore, age estimation plays a massive, highly controversial role in immigration and asylum applications. It determines whether an undocumented individual arriving at a border is granted the specific, robust legal protections and social care afforded to unaccompanied minors.
This high-stakes legal reality raises a massive ethical boundary for the clinicians tasked with performing these age assessments. You cannot simply look at a teenager and declare their exact birth date.
You absolutely cannot. The core ethical and biological principle here is understanding the margin of error. Biological age, the physical maturation of the body's tissues, does not perfectly track with chronological age, the exact number of days since birth.
Because everyone grows differently.
Human beings mature physically at vastly different rates depending on genetics, childhood nutrition, severe illness, and socioeconomic factors. Because it is biologically impossible to pinpoint a living person's chronological age to an exact calendar day, practitioners must provide a realistic, statistically valid age range.
And the text strongly stresses the direction of that scientific error, doesn't it? If a clinician is unsure, which way should they lean?
This is a fundamental human rights imperative. From a legal standpoint, the underestimation of age usually advantages the subject. For instance, treating a biologically mature 19-year-old as a 17-year-old keeps them within the protective juvenile system.
But the other way around is dangerous.
However, the overestimation of age medically categorizing a biologically immature 16-year-old child as an 18-year-old adult can severely violate their human rights, potentially subjecting them to adult prisons or denying them vital child asylum protections. Therefore, the clinical consensus is that any element of scientific doubt must result in an increased range of possibilities, giving the absolute benefit of the doubt to the individual to protect their rights as a potential minor.
So how do clinicians actually go about estimating age in a living person when the stakes are this high? The chapter outlines 4 main modalities of assessment, noting that they should be used in conjunction for the most accurate result. Let's walk through them.
The first modality is a comprehensive social and psychological evaluation. This is not typically performed by a forensic pathologist, but rather by a highly trained clinician, pediatrician, or specialist social worker. They assess the individual's cognitive development, their emotional maturity, their educational background, and their social interactions to gauge whether their psychological profile aligns with their claimed age.
The second modality brings it back to the physical body, the external estimation of age.
This physical examination must be conducted by a qualified clinician, often a pediatrician. For children and adolescents navigating puberty, this involves assessing Tanner staging.
What's Tanner staging?
Tanner staging is a standardized, globally recognized clinical system that categorizes the physical stages of pubertal development from stage 1 prepubertal to stage 5 adult maturity. The clinician assesses the development of primary and secondary sexual characteristics. By correlating the Tanner stage with population norms, they can estimate an age range.
A third modality is skeletal estimation. And this is where we hit a significant medical ethics hurdle.
Skeletal estimation is a highly objective measure. It typically involves taking localized radiographs or X-rays, usually of the non-dominant hand and wrist.
Looking at the growth plates.
Yes. The radiologist assesses the appearance and fusion of the epiphyseal plates, The cartilaginous growth plates located at the ends of the long bones, the radius, ulna, and the metacarpals and phalanges. These plates fuse into solid bone at relatively predictable age ranges as a person matures. Clinicians often use standardized references, like the Grulich and Pyle Atlas, to match the X-ray to a specific bone age.
But the ethical hurdle revolves around the use of the X-ray itself.
Precisely. You are exposing a healthy, living person to ionizing radiation. In a standard clinical setting, radiation exposure is ethically justified because it is used to diagnose a fracture or treat a disease. It provides a direct medical benefit to the patient.
But here, there is no medical benefit.
None. In forensic age estimation, the radiation exposure provides zero medical benefit. It is performed purely for legal, administrative, or border control reasons. Therefore, it requires the most stringent, fully informed consent from the individual, who is to understand the risks and the non-medical nature of the procedure.
And the fourth and final modality is dental estimation.
Dental development is generally considered one of the most reliable biological indicators of age, as it is less affected by malnutrition or endocrine disorders than skeletal growth. For prepubertal children, a simple, non-invasive visual intraoral inspection to observe which deciduous, or baby teeth, or permanent teeth have erupted through the gums is highly effective.
But for older adolescents claiming to be minors, visual inspection isn't enough because most of their visible teeth have already erupted.
Correct. For postpubertal individuals, practitioners must rely on dental radiographs, specifically panoramic X-rays, to assess the calcification and development of the roots deep within the jaw. They focus heavily on the development of the third molars, commonly known as wisdom teeth, which are the last teeth to develop and fuse in late adolescence and early adulthood.
But that circles back to the X-ray problem.
Exactly. Just like skeletal X-rays, this brings up the identical ethical issues regarding ionizing radiation exposure and informed consent.
It is a phenomenal intersection of biology, medical ethics, and international law. Okay, let's recap the core clinical and investigative themes of this deep dive. Identification is the absolute foundation of forensic medicine. Without it, the medical investigation of death is paralyzed. Reliable identification requires strictly distinguishing between primary, scientifically robust identifiers like DNA profiling, fingerprint analysis, and dental records, and the secondary supporting identifiers like surgical scars, tattoos, and orthopedic implants. We've seen how crucial multidisciplinary expertise is, from the odontologist stabilizing fragile calcined teeth with acrylic at a fire scene to the anthropologist utilizing regression tables to estimate living stature from a skeletal femur. And we've seen that whether dealing with a massive disaster victim identification operation or assessing the age of a living asylum seeker, the clinical processes must be rigorous, unbiased, well-documented, and legally defensible.
It is entirely about methodical, scientific truth-finding, replacing assumption with evidence.
All right, it is time for our rapid, single best answer recall prompts. Let's test those clinical frameworks we just built together. I'll pose the scenario, and I want you, the listener, to pause and lock in your clinical reasoning before the expert talks through the answer. Prompt 1. A body is recovered bearing a highly distinctive surgical scar on the abdomen, a specific pacemaker, and a wallet containing a driver's license. Which of the following is considered a primary identification criterion that can stand alone legally? A, the unique surgical scar. B, fingerprint analysis. C, the driver's license. D, the pacemaker serial number. Take a second to think about that.
Think about the legal threshold. The correct answer is B, fingerprint analysis. Fingerprints, DNA profiling, and dental comparisons are the only accepted primary criteria. While surgical scars and specific pacemakers are incredibly powerful, highly specific secondary criteria, and a driver's license offers circumstantial evidence, only the primary methods provide standalone evidential certainty. You can review the hierarchy of evidence in the methods of identification section.
Prompt 2. A forensic odontologist is examining a body recovered from a severe house fire. Based on the physiology of dermal tissue damage, which teeth are most susceptible to calcination and destruction during the blaze? A, maxillary mandibular molars. B, mandibular premolars. C, anterior incisors. D, impacted wisdom teeth. Just a moment to think.
Consider the anatomical protections of the mouth. The correct answer is C, anterior incisors. As the ambient temperature rises, the lips rapidly lose moisture and shrink away, completely exposing the front teeth to direct heat and flame, causing them to calcine. Conversely, the tongue swells and the thick tissues of the cheeks protect the posterior teeth, the molars and premolars. This crucial pathology is covered in the examination of dental structure section.
Prompt 3. Building on that scenario, what specific chemical material does a forensic odontologist apply at the scene to stabilize those fragile incinerated teeth before the body is transported to the mortuary? A. Plaster of Paris. B. Formaldehyde solution. C. Transparent cold cure acrylic. D. Cyanoacrylate fuming. Give that a second.
Recall the specialized scene intervention. The answer is C, transparent cold cure acrylic. The liquid monomer and powder polymer are mixed to a runny consistency and dripped over the delicate calcined teeth. It seeps into the pore as ash and sets solid, preventing them from crumbling during transport. Revisit the examination of dental structures section for this clinical pearl.
Prompt 4. A forensic anthropologist is attempting to estimate the stature of skeletal remains. Why is the direct head-to-heel measurement of an intact, newly deceased body physiologically inaccurate for establishing their true living height? A. Post-mortem bone demineralization causes shrinkage. B. The loss of gravitational pressure allows intervertebral discs to expand. C. Rigor mortis permanently contracts the long bones. D. Post-mortem pooling of synovial fluid swells the joints. Think about this one.
Think about the biomechanics of the spine. The correct answer is B. During life, gravity compresses the nucleus pulposus of the intervertebral discs. After death, this pressure is removed, and the discs absorb fluid and expand via osmotic pressure. Combined with total muscle relaxation, this causes the corpse to lengthen slightly compared to its living stature. Therefore, anthropologists rely on long bone measurements and regression tables instead. Refer to box 14.2 for the skeletal breakdown.
Prompt 5. In the United Kingdom, during a massive disaster victim identification operation, who holds the ultimate legal responsibility for chairing the Identification Commission and formally confirming the identity of the victims? A. The lead forensic pathologist. B. The chief constable of police. C. The local coroner. D. The head of the National DVI unit. Take a moment.
Focus on the judicial authority. The answer is C, the local coroner. While the DVI unit coordinates the immense logistical and police response, and the pathologists provide the scientific data, the coroner holds lawful possession of the bodies and acts as the judicial arbiter, reviewing the evidence to confirm identity to the required legal standard. This framework is detailed in the mass disasters section.
Excellent reasoning. Now, before we sign off, we want to leave you with a final thought to ponder.
We discussed the incredible, almost cellular sensitivity of modern DNA analysis. But consider the frontier of genetic investigation. As forensic science increasingly relies on civilian, commercial genealogical databases to identify unknown individuals, a practice that is revolutionizing cold case investigations by building massive family trees from crime scene DNA. How will forensic medicine and the legal system navigate the complex civil rights concerns regarding genetic privacy? Where exactly is the legal and ethical boundary between solving a decades-old crime and exposing the genetic data of an entire extended family who never consented to a police search?
It is a profound, unresolved medical legal question to ponder as you open your textbook. Thank you for joining us on this deep dive into forensic identification. We strongly encourage you to open Simpson's Forensic Medicine, Chapter 14, and apply these frameworks to your reading. Happy studying.